All right. Okay. All right, Mary, we'll go ahead and get started. So hi, everyone. My name is Jenny Winkler, Director at the Illinois Health and Hospital Association. And I want to thank you all, for joining us today. We've heard from a ton of great speakers, and we're going to continue to do so through our last session here around optimizing diagnostics and antimicrobial stewardship programs. So before we dive into the content, I just want to take a moment to introduce Dr. Mary Palmer. Dr. Palmer is a second-year critical care infectious disease pharmacotherapy research fellow at the UIC College of Pharmacy. She's received her PharmD from Ohio Northern University in 2019, and her clinical and research interests include antimicrobial stewardship, zoonotic infections, and gram-negative resistance. So I want to welcome Dr. Palmer and turn things over to you.
Thank you for that great introduction. So as she mentioned, my name is Dr. Mary Palmer. I am the second-year critical care and infectious diseases pharmacotherapy fellow at UIC College of Pharmacy. Today I'm going to be discussing optimizing diagnostics and antimicrobial stewardship programs with all of you today. I have no disclosures. The objectives for today's presentation include reviewing the impact and knowledge of rapid diagnostic tests, discussing diagnostic stewardship and its components, examining the rapid diagnostic test and the antimicrobial stewardship relationship, and then being able to recommend appropriate use of results from rapid diagnostic tests in clinical care, and ultimately be able to justify the use of rapid diagnostic tests at your specific institution. Before diving into the specifics of rapid diagnostic implementation, it's important that we first discuss the impact of rapid diagnostic tests, which is really just improving time to effective antimicrobial therapy. Many of us are aware of a variety of risk factors for patients who have multi-drug resistant organisms, such as end-stage renal disease, diabetes, invasive devices, etc. More are listed on the left side of the screen. But even
Mary,
yes.
Can I stop you for a moment? I'm sorry. I don't think your slides are advancing.
Oh. I see it advancing on my thing. Let me reshare, maybe.
Sure. Sorry about that.
That's okay. Is it on?
There we go. That looks perfect.
If I do this, are you able to? Did it advance?
Yep.
Okay. Okay. Perfect. Sorry about that. I don't know what was going on. Yeah. So this slide is really about the importance of early effective antimicrobial therapy. So we have these patients that come in with these risk factors for multi-drug resistant organisms, but we don't always like to use predictive scoring tools to help determine empiric antimicrobial therapy for these patients. Even if our patients check all the boxes for a multi-drug resistant organism, we still tend to be quite hesitant in broadening empiric therapy. So the best way that we can help aid in making that empiric therapy decision is implementing our rapid diagnostics to then help identify if there's a resistance mechanism sooner in these patients. So that will ultimately lead to an improved time to effective therapy. Looking at this multivariable analysis for serious infections on the right side of the slide, the significant variables associated with mortality are septic shock, high Apache scores, and inappropriate initial antimicrobial therapy. Of these risk factors, the only modifiable risk factor is that inappropriate initial antimicrobial therapy. So rapid diagnostics are a way that we can use to help decrease time to appropriate antimicrobial therapy and hopefully have a huge impact in patient care. Even if we did utilize predictive scoring systems in our everyday care more to help improve that time to effective therapy, they still cannot replace rapid diagnostics. This study compared the Verogen gram-negative rapid diagnostic system with multiple different predictive scoring systems to detect ESBL and Helicobacter. Verogen far outperformed all of the scoring tools that were assessed in analytic performance and as well as the rate of overtreatment. So utilizing a carbapenem for a non-ESBL organism and undertreatment utilizing ceftriaxone for an ESBL. So this further denotes that rapid diagnostics really are an ideal method compared to predictive scoring tools to further decrease that time to effective therapy and help improve patient mortality. Another question commonly posed is what actually is driving mortality? Is it multi-drug resistance or is it a delay in time to effective therapy? Both factors definitely play a role. This paper looked at patients with carbapenem susceptible and carbapenem resistant enterobacterales and also looked at initiation of effective antimicrobial therapy within at least 2 days or greater than 2 days. On the left side of this chart, those are patients who received appropriate antimicrobial therapy within 2 days, and mortality still increased twofold in those patients who had a carbapenem resistant infection versus the standard reference, which is a carbapenem susceptible infection. However, when looking at the right side of this chart, patients who received a delay in effective therapy, even with a susceptible infection, still had a twofold increase in mortality compared to those who did not see a delay in therapy. And those who had a resistant infection had a fourfold increase in mortality. So this goes to show that while resistant infections definitely can potentially affect patient mortality, delays in effective antimicrobial therapy further exacerbate that mortality risk. And this is where rapid diagnostics, again, can play a huge role in decreasing time to effective therapy and improving our patient mortality. To further highlight the importance of time to effective therapy, this is a breakdown of the prior study that I just discussed, looking at it more day by day. So in the patients who had carbapenem-resistant infections, overall mortality was higher than those who had a carbapenem-susceptible infection, but mortality did tend to increase the more empiric and appropriate effective antimicrobial therapy was delayed. And similar trends were also noted in those patients who had carbapenem-susceptible infections. So in those who had therapy started on day 0 in a carbapenem-resistant infection, mortality was 12.7%, but when that was started more than 5 days out, the mortality was increased to 20%. And again, a similar trend with the carbapenem-susceptible infections as well. Rapid diagnostics, however, by themselves are not as effective without active stewardship intervention. So the most important part of active stewardship intervention is the translation of genotypic results and then actually acting on the results of the rapid diagnostic test. But oftentimes other clinicians may ask, what does CTXM even mean? How does that change our current antimicrobial therapy? This meta-analysis found that rapid diagnostic testing in combination with active stewardship intervention significantly lowered patient risk of mortality, reduced time to effective therapy by 5 hours, and reduced patient hospital length of stay. The number needed to treat to prevent 1 death was 20. And this study really goes to show that ideally, rapid diagnostic testing in combination with active stewardship intervention should be standard of care at institutions who are implementing rapid diagnostic tests. One downside of combining rapid diagnostic testing with active antimicrobial stewardship intervention is the time and effort that goes into coordinating between clinicians and labs. Many institutions rely on real-time notification. I've been at institutions that have used a 24/7 blood culture pager, which does take a lot of time out of pharmacist's day. And many institutions also rely on utilizing these clinicians for the translation of these genotypic markers of resistance into antimicrobial therapy recommendations. Again, recognizing CTXM, knowing that that is a resistance gene for ESBL, and modifying therapy to carbapenem. One way, though, to help combat piling on this workload to just the stewardship team would be to potentially push some of that responsibility onto all clinical pharmacists or additional healthcare providers. So giving them the education and knowledge to be able to determine what these genotypic resistance markers are and to be confident and comfortable actively intervening on the rapid diagnostic test results. Additionally, there are some phenotypic rapid diagnostic tests, such as Accelerate Pheno, that can alleviate some of the burden of genotypic translation. Instead of having to decipher what CTXM means, it will just outwardly state if an organism is ESBL. One specific study did find that length of stay, time to optimal therapy, and duration of therapy were similar between patients where Accelerate Pheno and real-time intervention by antimicrobial stewardship was utilized versus those who just had intervention by antimicrobial stewardship and Accelerate Pheno. So there is opportunity, again, to potentially alleviate some of that stress and workload on the antimicrobial stewardship team by utilizing rapid diagnostics that just give you phenotypic results instead of our genotypic results. Not only is rapid diagnostic testing in combination with antimicrobial stewardship better for patient outcomes, it's just another huge part of rapid diagnostic justification is really related to monetary costs. So this study found that the rapid diagnostic test in combination with an antimicrobial stewardship program was the most cost-effective strategy. And one of the only two strategies that were not cost-effective were those that utilized rapid diagnostic tests without any sort of antimicrobial stewardship or any sort of antimicrobial stewardship intervention. So this again highlights the importance of that combination of active intervention in addition to our rapid diagnostic test implementation. As I mentioned, cost-effectiveness data does really reinforce the need for antimicrobial stewardship intervention with our genotypic rapid diagnostic tests. However, it can be difficult to generate true revenue strain on the microlab and the antimicrobial stewardship team. So the silo mentality is at play. The financial benefits of utilizing these tests are not necessarily seen by those who are actually running, interpreting, and intervening on these tests and their results. Additionally, not every rapid diagnostic test is the right fit for every institution. It's important to consider your specific patient population to tailor your recommendations. In a couple of slides, I'm going to demonstrate how to really go about choosing a rapid diagnostic test and comparing new rapid diagnostic tests to what your institution currently has. And that will give a good kind of a good walkthrough and example for how to go about picking a test just based on your specific institution as well. ID pharmacists and physicians are key members of the antimicrobial stewardship team. While antimicrobial stewardship intervention is important, we do need to recognize that not all members of the ASP team may be aware of the breadth and scope of the rapid diagnostic tests that are available. The first study on the left of this slide assessed ID pharmacist knowledge of rapid diagnostic tests. The majority of pharmacists were funded via an antimicrobial stewardship program and had worked with RDTs for about 3 years or less than 3 years. The most common rapid diagnostic test utilized was a multiplex PCR, but only a little more than half of pharmacists reported familiarity with this testing, and about a third had even assessed outcomes related to RDT implementation. The study on the right is out of Nebraska, and it assessed physician knowledge of rapid diagnostic tests. 60% of physicians stated that they would be able to adjust therapy based on a rapid diagnostic test result, but only approximately 30% had ever reviewed the institution's website that gave and laid out instructions for RDT interpretation. However, those that did had significantly better knowledge of the rapid diagnostic test interpretation than those who did not. So even specialists on the antimicrobial stewardship team can utilize more education and more awareness of these rapid diagnostic tests to better impact patient care and appropriately implement these and act upon their results. Now that we all better understand the economic and clinical impact of rapid diagnostic tests, we can really move forward with the next step in helping to implement these and further justify the rapid diagnostic testing. Preparation really is key when deciding to implement a new rapid diagnostic test. The primary goal is always to improve patient outcomes. However, we have to consider cost as well. A survey of 41 hospitals with an antimicrobial stewardship program showed that hospital and pharmacy administrators considered antimicrobial costs as the most important stewardship outcome. So while we clinicians view rapid diagnostic tests in terms of patient outcomes, our administration may look at these tests and want to know how it's going to affect hospital costs. These tests can be quite expensive, so developing a business plan upfront and prior to implementation and utilizing the variety of literature that's already available on this topic can really help clearly define how these rapid diagnostic tests are going to address our clinical outcomes, our process measures, and our economic outcomes. To help in the rapid diagnostic test justification process, these next two slides just provide a glimpse into the literature surrounding various rapid diagnostic tests. There's a lot more out there, but these are just a really great starting point and really for your information to have offhand. The first section of studies looks at the Varigene gram-positive panel. The first test was at a adult community hospital. Pharmacists responded to real-time RDT alerts between 7 and 7 and actively intervened on these results, and they found a decreased time to targeted therapy by 25.7 hours, a decrease in duration of therapy in patients who had contaminant by 17.8 hours, length of stay decreased by approximately 2 days, and hospital costs decreased by approximately $7,000. The next study was at an adult and pediatric academic medical center. Real-time stewardship alerts were intervened on between the hours of 7 and 16:30. It also noted a decreased time to antimicrobial switch by 27 hours and time to de-escalation by 29 hours. The next two studies are looking at the Varigene gram-negative test. So the first one was conducted at an adult academic medical center. Again, real-time interventions were made 24/7, and they noted a decreased time to optimal therapy by 10.8 hours. The last one was at an adult tertiary care and cancer hospital. They did not have any real-time alerts on rapid diagnostic testing, but they did have daily reviews for interventions. And even with daily reviews, they noted a decrease in 30-day mortality and a decrease in time to effective therapy for patients with an ESBL. And the last one is a study that looked at Accelerate Pheno, specifically with gram-negative organisms at an adult and pediatric academic medical center. They utilized real-time alerts with interventions and noted a decreased median time to first antibiotic by 6.3 hours and a decrease in antibiotic escalation by 43.3 hours and time to de-escalation by 13 hours. So there's really a lot of studies out there that are showing similar and really positive clinical outcomes. And then this last slide looked at the BCID film array. I won't go through every study because some of them are redundant, but overall, for gram-negative, positive, and even Candida species, studies noted decreased time to escalation, decreased time to de-escalation, decreased time to effective therapy, and decreased time to optimal therapy. So we're seeing, we're decreasing that time to effective therapy in a lot of these studies, which is great because we know that is a modifiable risk factor for patient mortality. In addition to utilizing a lot of the clinical data that's out there, implementing rapid diagnostic testing really does meet a variety of the core elements of antimicrobial stewardship programs, which is looked positively upon by hospital regulatory bodies such as the Joint Commission. So this chart really goes through each core element and how implementing a rapid diagnostic test helps fulfill that core element. So again, these next couple of slides are more for your information. I will just kind of go through a couple of them. So for example, under drug expertise, one of the core elements is having a pharmacist leader to improve antibiotic utilization. So typically the antimicrobial stewardship pharmacist generally performs daily antimicrobial stewardship interventions. The rapid diagnostic testing helps to streamline this process for antibiotic administration from pharmacy in a more timely manner. And it also helps to collect and analyze patient data. And then under actions, one of the core elements is to implement specific intervention to improve antibiotic use. So how this kind of helps fulfill that core element by utilizing prospective audit and feedback on positive blood cultures, we can help improve our antibiotic use. Rapid diagnostic tests are considered an advanced activity per the playbook as a diagnosis and infection-specific intervention. You can use rapid diagnostic tests to align with specific local institution needs, and by utilizing rapid diagnostic data, you can come up with measurable outcomes to help determine the impact of that rapid diagnostic test on patient outcomes in your specific institution. And this is another slide that goes over more of those core elements. So for tracking and monitoring, it helps improve process measures and monitoring compliance with specific interventions in place. So if we consider, think of a rapid diagnostic test, it's considered an intermediate activity to monitor a specific intervention per the playbook. Rapid diagnostic testing provides a tangible outcome to monitor and is a targeted intervention. And then outcomes do include like looking at patient mortality, length of stay, time to appropriate therapy, and time to optimal therapy. And under reporting, the core element that it can help is sharing outcomes with key stakeholders. So from the C-suite, it confirms continual antimicrobial stewardship program support, demonstrates a follow-through that the antimicrobial stewardship is accountable for these patients, and it just provides more accountability for this specific core element. The pharmacy director uses reporting as demonstration of pharmacy activities and impact, and then other stakeholders in the hospital may benefit as well. So potentially our groups in the ED or the ICU may benefit from getting information on a patient's blood culture sooner rather than later. So we know that rapid diagnostic tests are cost-effective, they improve patient outcomes, and can appease to Joint Commission standards. Now, rapid diagnostic tests can even help influence patient public opinion of institutions in their specific area. These figures are available to the public. The image on the left compares sepsis and septic shock care at 3 institutions in Chicago. Antimicrobial therapy is a huge part of sepsis and septic shock care that can be influenced by rapid diagnostic testing. The figure on the right shows C. diff rates at various institutions, and once again, these rates can be influenced by rapid diagnostic testing for C. diff specifically. So now patients are possibly able to even choose an institution to receive care based on outcomes that can be influenced by rapid diagnostic testing. This last section of slides is putting kind of what we talked about into use. So a retrospective analysis was done at my institution utilizing blood culture data from the previous calendar year. We looked at select rapid diagnostic testing platforms that were evaluated and compared. They were compared based on organism inclusion and then projected clinical and economic outcomes. The analysis was performed twice. So it was first performed on all positive blood cultures and then it was performed only on organisms for which antimicrobial stewardship intervention was also performed. So it did exclude suspected contaminants, anaerobes, and then any duplicate cultures. The next couple of slides walk through pathogen targets on a variety of rapid diagnostic testing, specifically the Glenmark ePlex panel, the BioFire film array, the Verigene, and then the Accelerate Pheno. Looking at this slide, this is looking at gram-positive bacterial targets and gram-positive resistance genes. So for Glenmark, you can see that it includes a lot more targets than the other three tests. Specifically, for this analysis, Glenmark was being compared to Verigene, and it covered a lot more gram-positive organisms and included a lot more resistance genes. The Accelerate Pheno doesn't provide really any resistance gene coverage, so that's something to consider if you're thinking about implementing Accelerate Pheno at your institution. In addition to having more gram-positive coverage, Glenmark also provides more gram-negative targets compared to the other three. However, if you look at the resistance genes that are included, they do actually match the resistance genes that are included on the Verigene machine. And then lastly, Glenmark provides the most fungal targets. Verigene actually does not include any fungal targets. So it's a more ideal agent when it comes to rapid diagnostic testing when there's a concern for a fungal species. Assumptions that were made in this analysis that we're utilizing the clinical and economic data we previously covered include excess hospital costs due to contamination, which was estimated to be approximately about $1,000 per isolate, a 2.5-day length of stay reduction with utilizing rapid diagnostic testing in addition to a stewardship program for missed pathogens, but that did exclude contaminants and fungal species. And at 2.5 days, that was approximately at our institution a cost of $1,255 per night, which would be about $3,138 per patient. The excess unnecessary empiric antifungal treatment with echinocandins. This was huge because, again, not all of these tests cover fungal species. So the average time to identification of candidemia via conventional microbiology is about 3.5 days plus or minus 2.1 days. And the average time to identification of candidemia using a rapid diagnostic test from a positive blood culture is about 2.5 days plus or minus 1.4. So the difference in time can range from 1 to 4.5 days per patient. The AWP for mycofungin, 100 milligrams, is $224.40 at our institution. So the estimated annual price savings, so getting these patients off of mycofungin and onto like an azole, for example, would range from about $224 to approximately $1,000 per patient. Organism inclusivity at our specific institution was compared as well among a variety of these tests. So looking at all of the tests, Glenmark did provide the largest organism inclusivity with 92% of gram negatives, 97% of gram positives, 93% of fungal organisms, and overall a 95% inclusivity of the total organisms that were isolated at our institution. And there really was not a test that came as close to inclusivity as the Glenmark ePlex. A cost savings analysis was conducted as well, utilizing those prior assumptions that were made. The overall cost savings was estimated for each assumption and then multiplied by the number of organisms missed for each test to calculate a total potential cost and a base cost. And then these were compared to Glenmark estimated costs. So this last row is showing the total savings of Glenmark, of utilizing the Glenmark test compared to Verogen, Accelerate Pheno, and BioFire. The total savings with the Glenmark ePlex far outweigh the savings of the other tests, especially when it came to echinocandin use. Again, kind of going back to that fact that Glenmark does contain more fungal targets and overall more pathogen targets compared to Accelerate, Verogen, and BioFire. Okay. Specific pathogen targets were then assessed at my institution, and the rapid diagnostic tests were once again compared for target inclusion. So this got a little more specific with the specific types of pathogens that were isolated at the institution in that calendar year. Once again, Glenmark is providing the most gram-positive coverage, including Bacillus species, Cyanobacterium, and Cutibacterium, whereas the other three tests aren't including those isolates, as well as Enterococcus species that are non-facium or non-faecalis, Lactobacillus species, and Micrococcus species. Same for our gram-negative targets, especially Morganella, Salmonella species, Serratia, and then Stenotrophomonas. BioFire does pick up those last three, but is still missing Morganella identification. And then Canada inclusivity was vastly more with Glenmark versus others. The only one that came close was BioFire, but Verogen and Accelerate had absolutely no target inclusivity when it came to our Canada species. And then, sorry, are you, I think something happened. Sorry, I'm so sorry.
It's okay.
I don't know what happened.
Yeah.
It just like closed out.
Okay.
Hold on. Okay, well, let me see.
You can try resharing again.
Yeah, I'm going to try that. Yeah. Sorry about this.
Good. Thank you. Thanks for sticking with it.
Yeah. All my technical difficulties today. There's not much more. So we should still be able to finish in the allotted time.
No problem. As Mary's pulling her slides up, if anyone has any questions, feel free to drop those in the Q&A box on the right-hand side of your screen, and we can, if we have time, we'll answer some of them. Otherwise, we'll pass them along to Mary after today's session.
Okay. It should be back up and running here in a second.
No problem.
Are you able to see my slides?
Yes.
Okay, perfect. Sorry about that.
Nope.
Okay. Yes. So we then also compared the specific resistance mechanisms that we have detected at my institution to see if those are then included in each specific rapid diagnostic test. So MEC-A, VAN-A, CTXM, OXA, and KPC were all detected on ePlex, Verogen, and BioFire, but were not detected on Accelerate because Accelerate doesn't have resistance mechanism detection. From that information, we then created a hospital-specific genotypic phenotypic antibiogram which helps with antibiotic decision-making. So this was looking specifically at Verogen. The positive predictive value and negative predictive value were both very high for these specific gram-negative organisms and resistance markers. So for example, looking at E. coli, so for specifically for E. coli, the negative predictive value for Veregene to detect CTXM is 98%. So for patients who are growing in E. coli and the Veregene does not detect CTXM, we can then safely de-escalate antibiotics to ceftriaxone. This was specific to our institution and to isolates at our institution, but it can be helpful, especially with and like therapy de-escalation. We use rapid diagnostics a lot for escalation, especially if that resistance gene is detected. But this gives some good data to support that we can comfortably de-escalate therapy just based off of the Veregene results. This is an additional genotypic antibiogram. This one looks at specific organisms, the resistance markers, and then it lists a variety of antibiotics at the top. So for this specific antibiogram, if we look at Acinetobacter, for example, if no resistance marker is detected, meropenem covers approximately 80% of strains. If oxa is detected, meropenem is then not as effective and covers approximately 13% of strains. For E. coli, if we do not detect a resistance marker, ceftriaxone can be used and to cover about 98% of strains. If CTXM is then detected, obviously ceftriaxone is then not as effective and only covered approximately 1% of strains. For Klebsiella oxytoca, if no resistance mechanism was detected, ceftriaxone covered 94% of strains. And if CTXM or KPC was detected, ceftriaxone did not cover any strains. So this is also a good way to utilize your rapid diagnostic testing and provide an antibiotic recommendation and potentially create pathways for your clinicians to use inpatient to help really interpret rapid diagnostic tests. This is that same sort of antibiogram, this time looking at Klebsiella pneumoniae, Proteus, and Pseudomonas. So for Klebsiella pneumoniae, if no resistance marker was detected, ceftriaxone covered approximately 98% of strains, but it covered 0% of strains where CTXM was detected. And for our strains where KPC was detected, meropenem covered only about 8% of strains, and 50% of strains where oxa was detected. For Proteus, at our institution, for ceftriaxone, nothing was identified. It covered 97% versus 0% if CTXM was identified. And for Pseudomonas, we did find that if no resistance markers were identified, that cefepime covered approximately 84% of strains, which was more than our meropenem and Zosyn, which are other big pseudomonal agents. So meropenem covered only 80% of strains, whereas piperacillin and tazobactam covered 81%. So again, these are really, really helpful and can be helpful in creating pathways similar to this. So this is very specific, again, to my current institution. If a patient comes in, has a growing a blood culture, gram stain shows it's a gram-negative organism. If KPC is detected, we can then interpret that as being a carbapenem-resistant Enterobacterales, so CRE. And at our institution, ceftazidime, avibactam, or meropenem-vaparbactam are our preferred agents of choice in that instance. If NDM is positive, we also know that that is a CRE, and our agents of choice are either ceftazidime, avibactam plus aztreonam or cefiderocol. If oxa is positive, again, we know it's a CRE, and our agent of choice is ceftazidime, avibactam. For CTXM, we know that is ESBL, and at our institution, we use imipenem as our carbapenem. And if no resistance is determined, and we know that it's E. coli or Klebsiella pneumoniae, we can comfortably de-escalate to ceftriaxone utilizing the data that we collected from from Ferrigine that I showed in a couple slides back. If it's Citrobacter or Enterobacter, cefepime is our agent of choice because those are AMP-C producers. And then just based on our antibiogram, our Pseudomonas agent of choice is cefepime or piperacillin tazobactam because those both provided greater empiric coverage than meropenem. Now, all of the data available is really focused on rapid diagnostics for bacteremias. There are some new rapid diagnostic tests that are out for bacterial pneumonia specifically. There's still not a lot of data around these, so in order to best kind of help justify these tests at your institution, we really need similar clinical and economic data. However, the impact will also be more difficult to measure because it's more difficult in respiratory cultures to establish a colonization versus pathogenesis. So these two tests are the BioFire Film Array Pneumonia Plus panel and the Univero Hospitalized Pneumonia panel. The BioFire test offers, you can use it off of more specimens than the Univero. So you can get sputum cultures, endotracheal aspirates, or BAL. It is a quantitative test. It's semi-quantitative for bacteria. The turnaround time is about an hour. It includes a variety of bacterial targets. Both tests have similar targets, but the BioFire test does also include viral targets, which the Univero does not. And then both also include a variety of resistance genes as well. But again, all the data we currently have to justify our RDTs are more focused in blood cultures and bacteremias, so it might be more difficult to justify these specific RDTs at your institution at the current moment. But as more data comes out regarding these, that will be more helpful in helping with implementation and justification. So to summarize, the use of rapid diagnostic tests in combination with our ASP intervention improves clinical outcomes and decreased costs in our patients with bacteremia. Specifically, pre-implementation and planning are crucial for justifying and optimizing rapid diagnostic test use. RDTs can aid in optimizing empiric and tailoring definitive antimicrobial therapy, especially based on a pathogen genotype-phenotype relationship, and that's where those genotypic, phenotypic antibiograms can be super useful for patients. Future directions. So we don't really have tests out right now that provide universal pathogen coverage. We may see conventional microbiology replaced with more rapid diagnostic tests in the future. We're starting to see platforms now for lower respiratory infections like the BioFire. Sorry, this stopped. Okay. Like the BioFire and the Univero tests. There are newer rapid diagnostic testing that are coming out that are direct from specimen. So we don't need to wait for actual bacterial growth to identify an organism or a resistance gene. And then just more randomized controlled trials are really needed for our rapid diagnostic testing, as a lot of the data is like retrospective analyses. I would like to acknowledge Dr. Eric Lenzler for his help with this presentation and apologize again for all the technical difficulties that I had. And I'd now like to open it up for any questions any of you might have.
No problem. Thank you. Thank you so much, Mary, for going through all of that. So yeah, everyone that's still on the line, feel free to drop your questions in the under the Q&A tab on the right. I have a question just to get things started. For a hospital that's maybe new to integrating the rapid diagnostic testing or is early on in their journey, where do you recommend they start? There's a lot of considerations, a lot of things to take into consideration. So, if you could give them one piece of advice, what would that be?
will for those like newer hospitals really trying to get their foot in the door with rapid diagnostic testing, honestly, starting with just a business plan, knowing your patient population, knowing the types of pathogens you're seeing commonly at your hospital will be vital in helping to decide what test is most appropriate for you, as well as ensuring you have the manpower to actively intervene on tests would be really important as well, because you could implement these rapid diagnostic testings but not have enough time and effort to put into actual interventions and intervening on these, so the tests aren't as effective, and it could potentially then just be money thrown down the drain. So really starting with that business plan and that preparation, knowing your population and knowing the capabilities of your pharmacists and clinicians is the best way to kind of start that rapid diagnostic journey.
Perfect. Thank you for that that comment. And we have a couple comments in the Q&A about, thank you for sharing all of this great overview, lots of the sharing the local data, much appreciated. This is a great presentation. Also integrating, the economic impact of bringing on these rapid diagnostic tests, I think is also key. So thank you for sharing that. We'll give it another moment. Don't see any questions at this time. So for everyone on the line, I know our agenda had called for everybody to come back to the main stage for a wrap up, but I think that we'll be able to sign off today's summit. Evaluation information will be sent to everybody in the next couple of days. So you're able to log off after this. And Mary, I don't see any more questions at this time, but again, thank you so much for your time and your presentation today. We truly appreciate it.
Yeah, thank you.
Have a great afternoon, everyone.
Yeah, you too.
Thanks.